All right, there's our cue. Good evening, everybody. 8:30 East Coast time means time for another National Fellow Online lecture. I'm Craig Pille. I'll be your moderator today, and we have a great lecture coming up for you for shoulder and scapula injuries and conditions in the overhead athlete. Dr. Charles Kenyon is here with us today. He's a musculoskeletal and sports medicine physiatrist with board certifications in both physical medicine rehab as well as primary care sports medicine. Currently a clinical assistant professor within the Department of Rehab's Medicine at University of Washington. Prior to medical school, Dr. Kenyon served as a performance specialist and coordinator of sports science with the Seattle Mariners and actively maintains credentialing as a certified strength and conditioning specialist through the National Strength and Conditioning Association in order to best serve active patients of all ages and abilities. His current research interests include biomechanics, injury prevention, performance optimization, and sports-related concussion. He completed his sports medicine fellowship at Emory University, where he served as chief fellow as well during the 22-23 academic year, and currently serves as team physician for USA Paraswimming and UW Men's Club Lacrosse. Most importantly, though, Dr. Kenyon was recently named assistant infield coach for the Laurelhurst Northeast Seattle Little League Farm One team. So big props to him, and thanks for him being here. Very briefly, as we all know here, goals of this program is to serve as an adjunct to all of your home programs, educational content, and provide fellows across the country with direct access to educational experiences with other AMSSM members, and also hopefully to assist in CAQ exam preparation. I think today is a really high yield topic, so I'm glad you're all here and or listening later. Please mute all your devices' microphones, turn off your video, submit all questions through the chat, and we'll get to that Q&A at the end. I'll make sure I touch on as many questions as we can get to. And then please complete the evaluation at the end of the lecture, some more about that. We want your input. We'd love to hear if there are any topics or speakers that you guys have suggestions to contribute to this project, kind of a crowdsource. There's two ways to reach out and get us that information. You can go to amsssm.org and fill out in the education tab. The Fellow Online Lecture Series has a link there that you can submit some requests or suggestions. And then there is a QR code here. Again, the primary goal of this lecture series is to assist in CAQ preparation. So if all you guys are preparing for the CAQ and seeing things that you feel like we have not had a lecture on in some time, please do notify us and let us know. But with that, without further ado, I'd like to have Dr. Kenyon take the floor and get things rolling here with some overhead throwing medicine.
Awesome. Thanks so much, Craig. Let's get this pulled up here. It's really cool and fun to come back now as an attending and take part in this lecture series. This is a resource that meant a lot to me as I was going through my training and fellowship, and I certainly still go back to high yield lectures and enjoy having the opportunity to hear from sub-experts across our organizations. That's one of the things that's so beautiful about sports medicine is that we have so many disciplines coming together to share expertise. So again, today we're going to be talking about the shoulder and the scapula, specifically conditions related to the overhead athlete. And going to try and keep this as pertinent in the CAQ realm as well. Certainly this could be a really big topic. You can break this into several sub-lectures if you wanted to, but we're going to try and hit the high yield fundamentals for the CAQ and bring up a couple points to stimulate some interest for people moving forward. So I also want to just take a quick second and shamelessly plug our upcoming symposium here at University of Washington, Seattle, April 5th and 6th on a very similar topic. We're having this day and a half symposium. A lot of the content that you're going to hear, especially on the scapula side of things, comes from Ben Kimbler and Eric Shasha, who will be coming out to Seattle to share their expertise, and also Sue Falsoni, giving perspectives as a physical therapist and athletic trainer who's worked heavily in the upper extremity world as well. So if anyone's in the area, we'd love to see you and continue to learn more together. So our objectives today, again, are going to be to understand the structure and function of the shoulder complex, particularly as it pertains to overhead athletic movements. We're going to work to appreciate principles of the kinetic chain as they apply to injury and performance in the overhead athlete, and correlate biomechanical phases of the throwing motion with common and unique injury mechanisms at the shoulder. So one thing I really love about the shoulder and biomechanics and the connect chain is there's this clear interplay between mechanics, injury prevention, and performance, and oftentimes these go hand in hand. And I just find it really fascinating from an academic perspective. I do come from an osteopathic background, and I think one of our tenets that plays really well into this is this concept that structure and function are reciprocally interrelated. So, especially at the shoulder, we'll touch on some of the unique anatomy that allows people to do crazy things like throw a baseball 100 miles an hour. We're going to focus on baseball as our model for this talk, but I just want to emphasize that the concept of the overhead athlete and the kinetic chain is really common across a lot of different sports, whether it's baseball, softball, tennis, volleyball, throwing field sports such as javelin, shot put, discus. I even put rotational sports such as lacrosse and golf into that same motion. Even as you can see in the picture here, swimming involves a lot of overhead activity we don't always give it credit for. Before we get into the nitty-gritty of the anatomy and biomechanics and kind of physics of things, I do like to highlight this injury model that Jason Zaremski, one of our AMSSM colleagues, published out of a couple years ago in 2019. It was developed with the idea of the adolescent throwing athlete, but I think it's something you can apply to any thrower or overhead athlete at any stage of their career. Just recognizing that injury is a very complex thing. You have both intrinsic risk factors, exposure risks, volume, training loads, also developmental risk factors. And these really put an athlete at a predisposed risk, but it's a combination of all these different factors that ultimately results in injury. So today we're going to focus on things related to the physical side of things, a little bit on mechanics, but I do want to acknowledge there's a very complex environment that ultimately results in dysfunction and injury in these cases. Starting with the basics of the shoulder joint, walking through things. You look at a picture like this, might seem pretty simple. We got the humerus, the scapula, the clavicle, not too much things to worry about yet. But we step back, then we layer that on top of the rib cage. And you can see how the shoulder is really built for mobility. And in order to achieve that mobility, oftentimes we sacrifice on the stability side. So this whole scapula, humerus, shoulder complex is really just attached to our axial skeleton here at the sternoclavicular joint. Everything's more or less floating in the area. We think about our shoulder joint classically as this glenohumeral joint, but we really have five different articulations: the sternoclavicular joint, the scapulothoracic articulation where your scapula's sliding on your rib cage, that classic glenohumeral joint that you're probably getting really used to thinking about. Subacromial space, so is another one we commonly think about. Then also that AC joint's in there, connecting the scapula to the clavicle. So as we keep layering structures on top of this, so we just talked about we have this glenohumeral joint interacts with the scapula, creates a lot of mobility through the shoulder. So structures that help create stability. First layer of that line of defense is often the shoulder labrum, which is a fibrocartilaginous complex that attaches to the rim of the cartilage, kind of deepens that fossa of the glenoid, helps to centrate the humerus and provide stability. We'll see some more images later, but also just an anatomy reminder that that long head of the bicep travels up through the groove and essentially is contiguous with that labral structure, which will be important as we talk about more pathology moving forward. We also have our static stabilizer of the shoulder. So that's the joint capsule, the various ligaments. Um, they're layered on top of that glenoid, on top of the labrum, and help provide some static stability to the shoulder. We're getting from there into our dynamic stabilizers, things that we've thought about a lot, the rotator cuff muscles. We don't always emphasize that the true function of the rotator cuff is really to stabilize the shoulder, particularly during dynamic movements. But in individual motions, our supraspinatus certainly helps to initiate that initial abduction. Infraspinatus and teres minor contribute to external rotation and the subscap and internal rotation. But in conjunction, they are helping to keep that ball and socket in place. Thinking about continuing to expand our view here. Now we're talking about the scapular musculature. We're going to think about things like the trapezius, both the upper, middle, and lower fibers attaching on the scapular borders. These levator scap muscles on the superior medial border connecting to the upper parts of the cervical spine. muscles such as serratus anterior we'll get into a little bit more, wrapping around the rib cage, attaching on the anterior portion of the scapula, and then these rhomboids attaching on that medial border. And things you might not think about as much as well. There's some attachments of the tricep and deltoid. In total, there's something like 17 different muscles attaching to the scapula, which we may not appreciate until we're getting through this fellowship level. Other muscles that we're thinking about, the pec minor, originates from the third to fifth ribs, inserts on the coracoid process, beyond the scope of tonight's talk, but there's other excellent fellow lectures on neurogenic thoracic outlet syndrome, but certainly the pec minor overlies the brachial plexus and the subclavian artery and vein, can be implicated in conditions affecting the brachial plexus in throwers and overhead athletes. When it's tight, or just the action of the pec minor creates pulling on the coracoid, creates protraction, internal rotation of the scapula, and downward rotation. We'll get in a little more about what that means. But a muscle that's commonly implicated in dysfunction through the shoulder. Other things that come in and attach in the shoulder, the lat and the teres major. This is a nice image from a paper recently published by a current fellow, Dr. Pagan. But you see how these muscles wrap around, attach onto the humerus, assist in extension, also can create some internal rotation, and are part of that shoulder complex to think about as we continue to work through this. How do all these different muscles move and activate? There's certainly complex nervous structures coming through the shoulder. Things we think about are the suprascapular nerve off the upper trunk, nerve root C5 and 6, innervating supraspinatus, infraspinatus, traveling through this suprascapular notch, and then lower down spinal glenoid notch. Can be affected by things like labral tears, creating paralabral cysts, and also based on scapular function, can create some tilt, create some entrapment in that area, leading to dysfunction as well. Axillary nerve traveling through the quadrilateral space. The borders of the quadrilateral space are the humerus, teres minor, teres major, and then the long head of the triceps is an area that can get impinged and cause difficulties. And lastly, on this image, the dorsal scapular nerve, as it coming from the C5 nerve root, will travel through the middle scalene and then back posteriorly, innervating both the levator trap and the rhomboids. Accessory nerve, that will innervate the SCM and the trapezius come into play when we're talking about our scapular function. It's a cranial nerve 11, coming out of the jugular foramen, and then running in those planes. So the SCM creates ipsilateral neck flexion, contralateral rotation, while the trap is intimately related with scapular movement, such as elevation, retraction, depression, and upward rotation. The long thoracic nerve that comes down and innervates the serratus. So the serratus that's coming from these first 8 to 9 ribs. Interesting anatomy in that it wraps around the rib cage and then attaches on the medial border at the anterior aspect of the scapula, and is very important in creating stabilization, aiding in protraction of the scapula, and facilitating upward rotation. We've thought about glenohumeral motion a lot in terms of how the ball and socket moves, motion such as flex extension, both in this kind of neutral, the scapular plane, which we talk about lining up with the scapula, abduction, abduction, adduction coming back. What's not pictured here, you can also have in the uh, horizontal plane, both abduction and adduction in the horizontal plane, internal external rotation neutral. That can also take place up in this 90-90 position. So like we talked about, a lot of different degrees of freedom within that glenohumeral joint. Then we stack up the scapula on the glenohumeral joint. So how do we achieve these big overhead positions? Kind of a high yield board concept there is this idea of scapulohumeral rhythm. So that's the idea that to reach these overhead positions, for every 2 degrees of glenohumeral motion, that the scapula is contributing 1 degree of, if you're elevating your arm, 1 degree of upward rotation in order to achieve that. And why is that important? Because as the arm moves up, we're trying to keep the glenohumeral joint centrated. So uh, that upward rotation of the scapula helps keep things in a place of optimal strength and stability in an otherwise super mobile joint. Getting into the different scapular planes of motion, there's things like elevation and depression, up and down, abduction, adduction. This is, we'll see a couple different terms in these slides, but upward rotation is when that inferior part of the scapula is kind of moving up again, trying to bring the glenoid into that overhead position. Similarly, in reverse, that's downward rotation. A couple models here. So other terms you might hear, medial and lateral rotation. But these are just some visuals here so you appreciate where these different muscular attachments, how they're interacting to create this complex movement in multiple planes. I think this is kind of a handy picture to visualize as this arm's moving up, the scapula is rotating upwards, again, getting this glenoid in a position where the arm can achieve optimal position. Also things like posterior and anterior tilt, internal external rotation. Why ultimately do we care about this? Why do we spend all that time? Because guys are out there, athletes are out there doing crazy things like throwing the ball 100 miles an hour. Uh, and how we achieve that is, we'll get into some concepts of the kinetic chain, but you see these contorted positions that are pretty extreme, and that's achieved through not only that glenohumeral joint, but forces coming up through the kinetic chain, contributed through thoracic extension, ipsilateral rotation. You have to have adequate uh, length at your pec minor on that coracoid to be able to get in this layback position where the scapula is upward rotating, and posterior tilting so you're getting that range of motion throughout the whole body and shoulder complex, not just through the glenohumeral joint. So that requires a complex interaction of your lower trap and serratus activation, and is ultimately much more complicated than just that ball and socket model that we may be more familiar with. Principles of the kinetic chain, that's the idea that segmental transfer of energy is going to come from the ground up. Again, those rotator cuff muscles, those are ultimately stabilizers, not primary movers. So you have to get a massive amount of energy somewhere, and that's through using the lower body, transferring energy from the ground up distally through the kinetic chain. So specifically, again, using the pitching motion as a model to study this, we talk about 6 phases of pitching motion that have been well described and fairly consistent for several years now. Starting with the windup, early cocking or stride phase, late cocking, getting into maximal external rotation, and the arm acceleration phase, deceleration of ball release, and then the follow through. What does that look like in full speed? So you can appreciate how rapid and ballistic that motion is happening. We'll step through it kind of now in slow-mo, appreciating this wind up. We'll go through each phase here as we get going, but this is just a nice graphic coming up balance centered. You start to move forward in our stride phase, foot contact in our cocking phase, external rotation, ball release, deceleration, and ultimately our follow through there. In the wind up phase, we're thinking about initiating the motion from the dual leg stance. Ball comes out of the glove, arms flex forward. Our center of gravity is moving over the stance leg with our body rotating away from the plate. Stride leg elevates, and we're getting this kind of maximum balance point at the max knee lift. So a lot of this is about setting up the center of gravity in a optimal position to then transfer force through the ground, shoulder, and ultimately the ball. So we have very low activation of the rotator cuff here. Really, it's about, again, setting up a stable base. So you want to make sure you have strong hip abductors, knee extensors, make sure your base is strong to set up the rest of the movement. Stride phase, again, coming from that balance point, moving the center of gravity forward up until the point of foot contact. Stride legs extending towards the batter, and the stance leg, that back leg, you're getting this triple extension through the ankle, knee, and hip, creating force that's going to go up through the hips and then ultimately through the trunk. So the hips are starting to open, rotate forward. That happens in somewhere between 400 to 700 degrees per second, and we're storing and creating elastic energy. You'll notice how his shoulders are staying what we call closed, so his hips are ideally starting the rotation first in the sequence up through the trunk, and then distally. This phase is going to end with stride foot contact. So again, we're thinking about our scapular stabilizers. They're starting to move that scapula upward in rotation, getting that arm into a power position. Deltoid is doing some work to get the arm abducted. Rotator cuff again is stabilizing that humerus within the glenoid. And our scapular stabilizers are very active as well. In terms of like hip range of motion, what can affect things there? So if your stance leg hip is restricted in internal rotation, then you will affect your ability to effectively rotate their hips. And similarly on the stride leg, if you can't achieve external rotation, then you may lay your foot down either open or closed, depending on your compensations. Cocking phase, this kind of transition between cocking to accelerations where we think about a lot of the peak forces and injury mechanisms happening. So the cocking phase begins after the stride foot contacts the ground, up to the point where we achieve this maximal external rotation of the shoulder. The trunk's rotating forward. Scapula is retracting, upwardly rotating like we discussed to get into that layback position. And maximal glenohumeral rotation is the end of the phase. And injury considerations here, again, those dynamic stabilizers, particularly the internal rotators really working hard to stabilize things. Biceps tendons very active. And this is where you'll see peak rotator cuff activity again to keep that humerus centered within the glenohumeral joint. Actually, like we discussed initially, static stabilizers are also very important in terms of your glenohumeral ligaments, your capsule, your labrum, and through repeated actions of throwing a ball, you can ultimately develop some micro instability and laxity that will impact some of the injuries we'll talk about here in a little bit. What you also will see is high levels of activity through that front leg, working to firm up that front side and assist with that force transfer more proximally through the kinetic chain. So from that externally rotated position, that's where we enter our acceleration phase. It begins as at maximal external rotation, then through ball release, you're having powerful internal rotation occurring here. It's very explosive, occurring somewhere between 7,000 and 9,000 degrees per second. Many people refer to that as the fastest kind of documented movement within sport. So it gives you just a sense of how much speed and force is going through the shoulder at that time. Something people talk about is your kind of arm slot. Generally, what we found is that the shoulder abduction is pretty consistent around 90 degrees in most thrower, and that arm slot is actually modified largely by the degree of lateral trunk tilt. So here, your lat and pec major are working hard to internally rotate the humerus. Subscap again is working hard to stabilize the humeral head, and you do have some posterior restraint from factors such as the teres minor. In deceleration, so that's the point after ball release and to the point where you're getting to maximal internal rotation, working to decelerate the arm. That's where a lot of this eccentric force is going to be placed on the shoulder complex. So large eccentric forces opposed to your shoulder, that's through the scapular stabilizers, the external rotators, even the posterior deltoid. Also, your biceps and the biceps tendon is undergoing some stress as they're working to decelerate elbow extension. Follow through, that's that last bit of the throwing motion from max internal rotation into your fielding position, sometimes referred to as more passive phase. Your body's essentially catching up. The arms continue to adduct across the body to safely dissipate those forces, as well as our elbow moving into some flexion. So again, ideally, most of the eccentric force has been dissipated by this time. There's lower activation, and we're just working to get back into an athletic fielding position. So again, to kind of loop that all together after a lot of talking, here's what that looks like again, kind of in full speed. So hopefully that gives you an appreciation for how much is going on in these 6 different phases, where the motion itself is very brief and explosive. So, in seeing a thrower, what do I kind of focus on? The I think the hard habit to get out of is to see somebody, look at their mechanics, and give them a million pieces of feedback, which is going to overload them, confuse them, and be very difficult to kind of tease out. So I focus a lot on this kind of power position phase, getting people up into a good position, landing a good position to set up for those more explosive movements later in the throwing motion. So, like to see a good stride direction, make sure they're getting to home plate. Some would argue that landing a little bit close, so right-handed thrower a little bit towards third base can help set things up to utilize those lower body forces more efficiently. Looking at hip shoulder separation, so creating some sequencing. Ideally, those hips are rotating first, creating some elastic energy through the trunk and then through the shoulders. Similarly, you want to keep that lead shoulder closed at foot contact, allow the hip and shoulder separation to occur. Getting the arm up in a good position for success, this 90-90 position of 90 degrees abduction and elbow flexion, and also kind of hand positioning with the ball can be a very subtle thing, but um, has been shown to have some correlation with injury risk. So why do I focus there? There's is some evidence behind that. Glenn Fleissig out at ASMI in Birmingham, they did a study where they looked at, I believe, professional pitchers, assessed them, gave them some feedback, then about a year later, reassessed them and saw what they were able to change. So of the errors that were identified, they said about 44% of those flaws were able to be corrected, and the overwhelming majority of those flaws occurred at or prior to, or the flaws that were corrected were the flaws that were identified at or prior to foot contact, so earlier in that throwing motion versus those later phases. Once things are moving very quickly, it's very hard to make changes there. But if you're going to provide feedback, a lot easier and more effective to do that in a way that sets somebody up in a stable position and allows them to complete these ballistic and high level movements. Common errors you may hear about are things like hanging or dropping the elbows can be a sign of fatigue. um, the athlete may not be taking the time and energy getting their shoulder up in that power position. You may see drops in velocity, and in dropping that elbow, that's you can increase your loads on the rotator cuff and certainly the medial elbow and UCL tendon or UCL ligaments. um, Also flying open, so that's when you're losing your sequencing, rotating with the shoulders before the hips, so that results in decreased trunk rotational potential energy, therefore placing increased stress on the anterior shoulder and medial elbow. So doing this over and over can certainly create some adaptive changes with repeated throwing that can be to some extent normal in particularly young and high level athletes who are doing this a lot. Some of it's adaptive change that allows for performance. But when there starts to be shoulder pain involved, then we take this very seriously. So very normal to see increases in external rotation range of motion. We've moved, we still kind of consider topics of GERD, and I think that's important to have in mind for your CAQ. But really, most people who are thinking about this a lot are focusing more on the total arc of motion. So having about 180 degrees of total arc is really important thing rather than the glenohumeral internal rotation deficit on its own. But how are those defined? Otherwise, most people use a threshold around 20 degrees of limited range of motion uh, um, in internal rotation as defining that as a threshold for a GERD. It's a side-to-side difference, but again, taking into account that total arc of motion, so whether that's 110 in external, 70 in internal, or 135 externally, 45 degrees internally, those both add up to around 180 and are increasingly appreciated as more of an adaptive response, but certainly very important to compare side to side. In terms of strength, the internal to external rotation strength, you'll see cited as generally the internal rotators will be about a 3-to-2 ratio in terms of strength, and that again through the throwing motion, particularly the eccentrics, can lead to repetitive eccentric action, repetitive microtrauma, and weakness in those external rotators, where the internal rotators can are generally stronger, but again, just trying to stabilize the humerus into the glenoid. So why has GERD been such a thing, and why should you be aware of it for your CAQ? So you have a loss of internal rotation compared to your non-throwing arm that can affect your mechanics. You have internal rotation loss, external rotation gain. Again, as you're going into clinical practice, think more about the total arc of motion, but the tightening of the posterior capsule can lead to translation of the humeral head and lead to compensations and risks of impingement. So other kind of food for thought, we're very commonly measuring strength and rotation kind of in these neutral positions. But again, we talked about the importance of getting your hand on top of the ball, which is kind of a pronated position. There's been some studies that show in that pronated position that can affect your glenohumeral range of motion. So as you can see here, getting back to about 90 degrees with a neutral forearm, however, in pronation, loses some external rotation there. Similarly, this other group looked at the effect of cervical position on shoulder internal and external rotation strength. So you'll see this picture here where, of course, in the laboratory setting, but that's a position that looks awfully familiar to that power position that we were looking at through mechanics. And compared to having your neck at neutral, doing that isometric strength testing, they found decreased strength with the head rotated contralaterally to the shoulder, both in external rotation, that difference about 12%, as well as in internal rotation about 6%. So I think just something food for thought as you're developing your physical exam skills, think about how this correlates into real life mechanics. That we need to take some of these positional and functional things into account, which I think is an ongoing goal for everybody. So in the young throwers, other things that can come up, the proximal humeral physis that closes somewhere between 16 to 20 years of age, so fairly late. Throwers and all youth sports athletes can be more prone to overuse injuries during their period of peak height velocity or their growth spurt. There's ways to calculate that using the average of your peak predicted adult height, which takes into account your own characteristics, your parents' height, and there's different formulas to calculate that. But the point there is that this peak height velocity typically occurs somewhere in early adolescence, 12 to 15 years old. And biomechanical studies have also shown that you're having the greatest changes in kinematics between 9 to 13 years old, and then kinetics rapidly change between 13 to 15 years old. So all that being said, when this peak during your growth spurt is also one of the biggest peaks where you're developing power, not only physically, but also in this throwing motion. So that's where we talk about little league shoulder and that risk group being in that overlapping 11 to 16-year-old range. Those are some of the factors that play into that. After skeletal maturity, then the shoulder structures that become more at risk are the rotator cuff and the labrum. And these are all compounded, as we talked about in that Zaremski model, by things like the rapidly changing kinetics and kinematics, the growth that can happen rapidly during that period, things like sport specialization and workload considerations as well. So this is what little league shoulder looks like. Some of the learning points here to make sure you get contralateral radiographs to be able to compare that growth plate side to side. You'll see that widening of that proximal humeral physis. So the rotator cuff attaches proximally around the physis. The pec major, deltoid triceps are attaching distally. So in this repeated external rotation action, that is placing stress in that growth plate area. Athletes will come in complaining of kind of vague shoulder pain, particularly in their throwing motion, and really this requires rest. So it's many of my colleagues will do as much as 12 weeks of rest even before kind of picking up a ball and getting into throwing progressions. So you want to get them a chance to rest, calm down, let the physis heal down, and then be really gradual and progressive about getting into interval throwing. progressions from there. So the risks are if you don't rest, then you can end up with a premature growth plate arrest and other complications of the shoulder. Also want to use this opportunity to address, things like mechanics, workload, things like that. I would also provide this cautionary case of one time when I get fooled in fellowship in my own continuity clinic. Had a young thrower that had arm pain. He had, not that kind of gradual onset we see with little league shoulder, but did have kind of a pop sensation, but was presenting a lot like little league shoulder. So I looked at his kind of AP views very carefully. Didn't look at the axillary view as closely as I could have. He wasn't recovering. He wasn't super compliant. We'll say that too. But as he wasn't recovering after about 2 months, it wasn't demonstrating even any real arc of improvement. We did go ahead and get an MRI, and we saw this lesser tuberosity avulsion from the subscap. And then kind of following up on 3 months to repeat some x-rays, and then you see that lesser tuberosity avulsion to be more apparent there. Um, fairly faint and subtle in this initial encounter, but could have certainly been picked up on earlier given the history and things like that. So my learning point there is not to just assume that all youth athletes are going to come in with little league shoulder. Something to be aware of is Pitch Smart guidelines. Gives a kind of outline for age appropriate recommendations, how many pitches per day, how many rest days you need after an outing, other things. They try to delay the onset of breaking pitches, trying to allow for some rest throughout the year. So young pitchers, giving 3 to 4 months of rest through the year, and avoiding kind of dual positions that involve a lot of throwing, like pitcher and catcher together. So Dr. Zaremski, Dr. Bowers, Dr. Kriz recently published this review article kind of looking at pitch count recommendations, how those vary by state, and kind of asking this question. This graph from their paper is looking specifically at UCL surgeries, but um, even despite the implementation of pitching guidelines, that we're still seeing increases in injuries. So what else do we need to think about? Is this model adequate, or do we need to come up with a new paradigm? So things they talk about in their review paper, enforcing policies. So certainly there's difficulties with compliance. Athletes participating in different leagues aren't necessarily going to be tracked in the same way. Working to standardize those expectations, and providing some additional recommendations for how many pitches per game and how to handle that. Also, talking about, I think one thing that gets undervalued is this importance of this formalized preseason warm-up period. So I am fully on board and agree with those recommendations to mitigate rapid increases in acute on chronic workload. And then also some thoughts about weighted ball programs, which will be outside of our scope tonight. Getting into more adult pathologies, this concept we touched on a little bit, the microinstability, internal impingement, and we talked about GERD a little bit. But in late cocking and early acceleration, that's where we're seeing maximal abduction and external rotation of the shoulder. In repetitive throwing motions, the shoulder goes through under changes to bony anatomy. There's can be changes in the capsule ligamentous structures, especially at the posterior capsule. And all these changes occur. You can get humeral retroversion in order with this goal of what the body's just essentially trying to create more external range of motion. So this microinstability can occur secondary to some of these adaptive changes in both the static and dynamic stabilizers, as we're trying to achieve super physiologic positions. So that creates some microinstability posteriorly, can create some adaptive changes, which may or may not be beneficial in terms of injury risk. And there's this concept of internal impingement, which is fairly unique to overhead activities. So internal impingement rather than that rotator cuff getting caught up in the subacromial space. Internal impingement is when part of that rotator cuff essentially is getting pinched there in the glenoid. So you have pathologic micromotion of that humeral head, get impingement of the deep surface of the supra and infraspinatus on the labrum and posterior superior glenoid rim. That over time with repetitive activity leads to fraying, partial tearing of the posterior cuff and posterior superior labrum. And again, this is, largely occurring during that late cocking, early acceleration phase where you're getting maximal arm abduction, external rotation. These athletes will present with posterior superior pain in the apprehension position. It may improve either with scapular traction or when you're relocating from apprehension. And generally, our physical therapy goals are work to stretching and mobilizing the posterior capsule, working on dynamic stabilizer strengthening, and increasingly we're talking about working on neuromuscular integration and optimization of the kinetic chain and motion of the scapula. POSTA injuries, these partial articular-sided supraspinatus tendon avulsions, those are more or less kind of secondary to this internal impingement process. So rather being more bursal-sided tears, we'll see these kind of distal articular tears associated with internal impingement, again, implicated during the external rotation, excessive movement that occurs during the cocking phase. It will be something that's more effectively diagnosed with an MRI arthrogram, whether labrum or articular-sided pathology. That may be something that comes up both clinically and exam-wise. And then surgical treatment, our goal is to manage these things conservatively, but the surgical approach often depends on the extent of the lesion. Another fairly unique pathology to the thrower is this idea of the Bennett's lesion, and that's extra-articular ossification of the posterior inferior capsule as it arises from the insertion of the capsule on the posterior inferior glenoid. So that may present with posterior shoulder pain, fairly unique to baseball pitchers in the literature. It can also be associated with other pathologies such as rotator cuff, or like we talked about the importance of this kind of micro instability that occurs with repetitive motion. So a lot of debate in terms of how this ultimately comes about, but some of the leading theories are things like subluxation and impingement of the humeral head on the posterior capsule, and then chronic traction that occurs in that posterior inferior aspect of the capsule with the repetitive throwing motion. Other things more traditionally is subacromial impingement, rotator cuff tears. Generally, we'll see these in older athletes, and very much less common to see full thickness tears. Usually, this is some attrition and partial thickness tear. Again, that kind of happens on the spectrum of tendinopathy through repetitive motion. Sites of impingement, actually, there's some evidence suggests that that's less commonly in that traditional subacromial area, but because of some of those anterior translating forces, some of that impingement can occur at areas like the coracoacromial ligament, coracoacromial arch. And again, thinking about that upward rotation of the scapula being important, as that moves up, can often clear space in those areas. So it's important to emphasize the scapular considerations as we're trying to mitigate the risks of impingement. Biceps tendinopathy. I'm sure everyone at this point has seen some degree of anterior shoulder pain in throwers or industrial workers who are doing a lot of overhead activity. So again, this is resulting from repetitive trauma, repetitive action through the long head of the biceps tendon as it travels over the lesser tuberosity. And as we're moving, so we have this traction force, but then as we're getting in that cocking position, so you don't have the traction, but the external rotation force. This anatomical model here is just a reminder of how intimately related that biceps tendon is, coming intra-articularly and integrating with the labrum. Slap tears, those are superior labrum, anterior to posterior tears, may or may not involve the biceps attachment. This is going to be one of the most common labral pathologies in overhead athletes, often associated with excessive internal rotation during the cocking phase, linked to shear forces and traction. Most commonly, we'll have a graphic here, but the type 2 slap tear is going to be the most common there. You have eccentric tension that is involved with deceleration phase. So as the arm's coming through, you'll get those large eccentric forces like we talked about that also place stress in that area. So this, is both the cocking end phase is the cocking into acceleration. Then also deceleration phase is where most stress is going to be placed on that biceps labral complex. Some may come on more gradually, some may feel a pop. Generally describe some vague, deep anterior shoulder pain. Not necessarily one specific exam maneuver. This is where it's important to be very comfortable with your full battery of shoulder exams. Again, trying to get the best detail on the labrum is going to involve getting an MR arthrogram uh, or high quality 3T study, but generally trying to get a good view of the labrum will involve a MR arthrogram. Treatment is still going to be guided towards initial period of non-operative treatment, rest, physical therapy. Operative, they move more towards debridement, and rather than trying to repair these things, often involves a biceps tenodesis. Again, looking at those traction forces there. Something that may come up, but just remind these type 2 tears would be the most common in the overhead athletes. So the type 1 is more the degenerative fraying. This type 2 is where it's kind of coming attached in that superior aspect. Type 3, you're getting into having a kind of a bucket handle lesion of the labrum there. And then in type 4, both detachment and some bucket handle changes. But type 2 is going to be the most common that you'll see in the athletic populations. This is just a reminder, kind of a meta-analysis of different surgical options, and one of the reasons why we really try to optimize conservative management, rest, address mechanics, and other physical therapy goals, because in a lot of these shoulder injury things, this is basically looking at rates of return to play after shoulder surgeries in, I believe, professional baseball athletes. So for something like a slap repair, that pooled average of return to play after a slap repair is only just a little bit over 60%. Similar for rotator cuff repair, somewhere around 50 to 60%. The lat repairs have been a little bit more reliable, but those are certainly smaller subgroups. So transitioning from more of those glenohumeral type pathologies to think about the scapula. So this is a case that came through my clinic recently, a 46-year-old male. This is what the referral said: acute left shoulder and neck pain, severely limited range of motion, had normal x-rays. He had been involved in a high velocity mechanism, was a motor vehicle accident. He had an MRI of his shoulder that he came in with, talked about some mild tendinosis of the rotator cuff, and then what the radiologist describes as possible muscle strain through the trap with non-specific diffuse edema up in the trapezius. So this is a picture of the patient shared with consent. Sorry, I should say left trap, but he had noticeable atrophy throughout his trap, had weakness with his shoulder shrug. If you look carefully, you can see that. So if this is midline, the scapula is resting nice and neutral, had some lateral deviation of scapula there, and demonstrated weakness and limitations in his range of motion. So because of some of that atrophy, my point on the MRI is to think about things critically. So there was edema on the MRIs and maybe from muscle strain, but those findings can also occur in the setting of developing fatty atrophy of the shoulder. So we had some concern for nerve injury. So this accessory nerve injury got an EMG, which confirmed that diagnosis. Again, this is a high velocity mechanism, but just taking a look at his scapular motion here, subtle, but especially as he comes down in the eccentric here, you'll see some of that prominence and loss of control compared to the contralateral side. Similarly, when it comes up here in abduction, you'll see those differences side to side, just how much effort is really trying to kind of compensate there. This trap's trying to fire, but really has no connection. So may or may not be athletic population necessarily, but I think it certainly is board relevant material to understand the innervations into these different muscles. So spinal accessory nerve, again, coming into that trapezius, the serratus being innervated by the long thoracic nerve, leading to these lateral or medial winging positions. So again, lateral winging, accessory nerve, trap weakness, medial winging, long thoracic nerve injury, serratus weakness, and you'll see that prominence more on the medial border. Again, just kind of a visualization here in terms of where those muscle attachments are coming and influencing on scapular movement. So more so what we'll talk about in our athletic populations, the idea of sixth scapula or scapular dyskinesis. So um, it was an embarrassing length into fellowship before I realized that sixth scapula was an acronym, not just a description, but that stands for scapular malposition, inferior medial border prominence, coracoid pain and malposition, and then dyskinesis of scapular movement. So it's caused by weakness in scapular stabilizers, things again like the serratus anterior, infraspinatus, the deltoid, lower and middle trap, tightness of the opposing musculature, such as the pec minor that we mentioned earlier. Ultimately, this altered range of motion can decrease the available space in subacromial space and predispose to impingement. Also can contribute to rotator cuff issues, capsular issues, and issues of the labrum. So when we see these changes, we'll get into a little bit more about a kind of systematic approach, but we want to emphasize strengthening the scapula stabilizers, the core, and have to have that solid foundation prior to moving on to the rotator cuff strength and then addressing our throwing mechanics. So we talked about the scapulohumeral rhythm, but just kind of doubling down on that. Again, this scapula, when we're coming overhead, is upwardly rotating. Every 2 degrees of motion at the glenohumeral joint, we're getting an extra degree of assistance from the scapula, and that's to maintain that good centrated position during complex overhead movements. Again, how that upward rotation, posterior tilt, aids the shoulder in getting into a externally rotated position safely and with minimizing risks of impingement. So historically, Kibler described 3 types of scapular dyskinesis. Type 1 being inferior medial border prominence, 2 where the entire medial border is more prominent, and then type 3 is super medial border becoming prominent. That was all well and good, but found to be the reliability of those assessments was limited. So they moved more towards just more of kind of a yes, no. Is there symmetric movement side to side? Is there prominence? And in a yes, no model that drastically increases the sensitivity and reliability. So I think taking on the scapula can be a very challenging task. And Dr. Shasha, Dr. Kibler have done a great job in their last few papers over the last couple of years, really emphasizing this kind of algorithmic approach and simplifying things to understand how the scapula is contributing. So first of all, our first step working down this algorithm, the top, obviously somebody's coming into your office because they have pain, limited function. So if someone with shoulder pain, and we're trying to figure out is the scapula contributing, first just kind of looking shirt off, going through these motions. Is there dyskinesis present? Yes, no. That'll guide you down your algorithm of how much attention you want to pay to the scapular dyskinesis. So that's as simple as we just looked at having the athlete elevate their arms 3 to 5 times. You can get more sensitive by increasing the repetitions, even giving them a 3 to 5 pound weight and observing any prominence of the scapula occurs with that movement. So we've identified dysfunctional movement. What are things that we can do to see again if the kicker here is that a lot of people have dyskinesis but may or may not have symptoms. So what we're trying to do in step 2 is determine whether that dyskinesis is leading to the pain or dysfunction. So that's where we talk about things like our scapular assistance test. We're going to anchor the scapula, facilitate upward rotation through that inferior medial border, and see if that improves, both the range of motion and any pain symptoms. Other things are the scapular retraction test. So you retract their scapula, get them a good position, have them elevate their arm. So before doing that, you'll test their strength, really lock down their scapula and retraction, test their strength again. Again, if they have improved strength or improvement in symptoms, then that is suggestive of dysfunction in that scapulothoracic movement. So we've had an athlete with shoulder pain, we've identified dyskinesis, we've done some corrective maneuvers and found those to help the symptoms. Now our job is to kind of step back and try and figure out what's causing the issue in order to guide a rehab plan. So Again, we just talked about the kinetic chain, trying to identify hip and core weakness, instability that may often involve something like a single leg squat, just a really solid, quick screen of core, abductor, um, strength and stability. If they have big impairments there, then obviously that's got to be a key point of your rehab plan. So other things that can happen are, acute avulsions or scapular muscular detachments. So you want to kind of palpate through that area, see if there's focal areas of pain, if there's any defect, that may be something that requires surgical correction. Going through your basics of your manual muscle testing. You want to keep your foundations going through that comprehensive shoulder exam. Also thinking about not only testing your normal kind of internal external rotation, but you want to challenge things like the rhomboids and lower trap. So things like this low row test can be very helpful. Having them push back, getting the activation from the low trap, extending that arm back into you. You can have them do that just in isolation, and then also cue them to kind of brace their hips and core and get a sense of how that core contribution affects the strength in that motion too. Looking at different muscle tightness, like we talked about different trouble areas, whether it's pec minor, upper trap, scalenes, lat, the posterior capsule, assessing those thoroughly and doing side-to-side comparisons. You want to see how good their control is. So can they retract and pinch back? Something to look at there. Again, taking into account serratus and trap weakness, getting into, again, our kind of standard physical exam, looking at the glenohumeral joint, ACSC joint, other clinical findings of glenohumeral instability, thinking about things like fractures that can change the attachment of the scapula onto the axial skeleton and lead to dysfunction. And like we talked about, neurologic deficits there as well. So in summary, the shoulder is a complex unit. Its motion is influenced by the kinetic chain, effects of energy transfer, and the effects of energy transfer through static and dynamic stabilizing structures. The demands of the overhead athlete are unique and influence pattern of injury and dysfunction across the population. Again, my osteopathic soapbox there, structure and function are reciprocally interrelated in both function and dysfunction. And a careful and systematic evaluation of the scapula is critical in the assessment of the kinetic chain athlete. How are we doing on time, Craig?
Pretty good. I think we got 3 or 4 minutes if you want to get through these cases and questions.
Yeah, perfect. Look at that. Every once in a while, you get lucky. So if anyone still is awake there on the East Coast, feel free to kind of type in your thoughts here in the chat. So for this case, we have a 18-year-old Division I freshman baseball player. He just pitched in 2 consecutive games, 25 pitches on the first day, 35 on the second day. They're playing in a championship game on the third day. His coach wants to get him back out there as a starting pitcher. Over the course, he's thrown 110 innings. His velocity is starting to decrease compared to prior games. He has that anterior shoulder pain and clicking sound that worsens with each pitch. His internal rotation of the glenohumeral joint is decreased by 25 degrees on his non-throwing arm. He's got positive O'Brien's, biceps loading, and speeds testing. So during which of the phases of the pitching cycle was he most likely to have developed this injury? So again, he's got anterior pain and some essentially findings of GERD. All right, so late cocking and deceleration. So going back, there's a lot of kind of distractors in here, but we have this anterior shoulder pain, the decrease in throwing velocity oftentimes is something that people present with. The internal rotation deficits, and then he's got positive labral signs. So this O'Brien's test, the speeds test, these are kind of biceps and labral tests. So we are thinking this is something like a potentially a biceps tendon or slap 2 injury. So again, those forces are the greatest during this late cocking phase and the external rotation, and again the eccentric forces during deceleration. So in question 2, which of the following statements is true regarding Little League shoulder? So take a second to read through there. So it's caused by repetitive loading of the shoulder, so both torque and then distraction that occurs over time. So I think the reason why B is incorrect is I think they are trying to get you to have um, kind of comparison views there. So again, another complex stem here, but 10-year-old right-hand baseball catcher presents 1 month of right shoulder pain, denies any acute injury. When the pain first started, he was pitching, and has since changed the catcher. His pain is getting progressively worse. Velocity and accuracy have decreased significantly. You're worried about little league shoulders, you get x-rays, you review the films, and the x-rays look normal, but the father insists that he continues to play and he takes ibuprofen before games. Then what's your next best step? So again, this is emphasizing the importance of having that contralateral comparison. So just because that facies may look normal, like I said, you may completely ignore axillary view because you're not paying enough attention, but to read those x-rays carefully, have the contralateral comparison so you can compare side to side, can definitely increase the utility of your diagnostic tools. So I included some of the key clinical references that we went through. That was, again, a million miles an hour. Thank you guys for tuning in. Many different approaches out there in terms of the scapula, but we chose to focus on that algorithmic approach that's going to provide you, solid tool set to build upon. I'm, happy to stick around for a little bit and be available if any questions are up there.
Yeah, Dr. Ken,
And thank you guys.
that was awesome. Thanks so much for being here with us and sharing your insights and expertise. Certainly, I think that really shone through in this lecture, while also really hitting on a lot of high yield topics. So, if there are any questions from the audience, I'd love to open up for a little bit here, and then certainly we won't keep Dr. Kenyon too long. But if there's any questions, feel free to hang around after the recording stops as well.
And
Awesome.
if helpful for anyone, I'm certainly happy to share the slides as well. But I will say, as my fellowship went on, especially getting into these last couple months, I encourage everyone to, tune in not only weekly, but really dig into the backlog of the lectures because it's pretty amazing what we've been able to accomplish as an organization and getting all that the content out there and having that resource available. So I think it's something I've really valued, and again, it's a true honor to come back now as an attending and get back.
Yeah, and absolutely. I think, for the fellows on the call, certainly, even just playing through the kind of the step-by-step throwing motion slides that Dr. Kenyon posed with a lot of the biomechanics sort of analysis there, I think can be very helpful and high yield and also, very helpful just from a kind of an understanding of all of this pathology, right? Rather than strict memorization, really kind of thinking through the process, I think can really help with a lot of the pathology that comes up here. Awesome. Well, thank you very much, Dr. Kenyon. I think it looks like we do have some good feedback for getting the slides sent out to some folks. So maybe we can arrange through Andy.
There's my email in the chat. I didn't want to put it on this last slide just when it ends up on the internet. But for anyone tuning in, reach out, or like I said, you can feel free to DM me through um, Twitter or X or whatever you want to call it these days, and always happy to engage. And I look forward to seeing everybody in just over a month out in Kansas City.
That's right. Awesome. Thanks so much, everybody. Enjoy your evening.
Thanks, guys.